Many thanks to the organizers for the invitation to discuss the Gilead TLR-8 agonist, selgantolimod, also known as GS-9688. Here are my disclosures. I first wanted to start by acknowledging the challenges we face to cure HBV. As we all know, both viral factors and host immune factors are potential barriers to cure. Examples of such factors include hepatocyte viral antigen presentation, persistent exposure to high levels of circulating viral antigens, and a tolerizing liver environment. It is hypothesized that these and other factors contribute to HBV-specific immune dysfunction and prevent viral clearance. At Gilead, like many other companies, our strategy is to develop a combination regimen which comprises both virus targeting and immune-based agents in order to achieve HBV cure. Toll-like receptors, or TLRs, recognize various pathogen-associated molecules and activate pathways which form the crucial first host defense against infections by linking innate with adaptive immune responses. Selgantolimod, or Selgan, is designed to have high absorption for pre-systemic activation of gut and liver immune cells, but also high hepatic extraction to limit systemic exposure and systemic immune activation. Once in the liver, TLR-8 agonists have the potential to impact either directly or indirectly both innate and adaptive immunity via activation of intrahepatic myeloid cells, which express TLR-8, inhibition of various immunosuppressive cell types, and also enhancing the frequency and/or function of various effector cell subsets. Selgan is a selective agonist of human TLR-8, giving a differentiated cytokine profile in human PBMCs relative to TLR-7 agonists. For example, although it does not induce interferon alpha, Selgan induces other antiviral cytokines in human PBMCs, such as interferon gamma and TNF alpha. In primary human hepatocytes with established HBV infection, Selgan-induced cytokines, conditioned media or CM, reduces HBV DNA, RNA, and antigen levels, but not cccDNA levels. However, treatment of PHH with Selgan-induced cytokines prior to HBV infection blocks cccDNA establishment. In human PBMCs, Selgan directly activates professional antigen-presenting cells, for example CDCs, and also induces immunomodulatory cytokines such as IL-12. As a consequence, in vitro Selgan treatment increases the frequency of HBV-specific CD8 T cells expressing the antiviral cytokine interferon gamma, although only in about half of the patients tested. Selgan treatment of PBMCs also enhances the cytolytic and non-cytolytic functions of NK cells, increases the frequency of activated follicular T helper cells, TFH, induces a dose-dependent reduction in the frequency of CD4 regulatory T cells or Tregs and myeloid-derived suppressor cells. Conversely, Selgan enhances the immunosuppressive potential of some subsets in vitro. For example, it induces PD-L1 expression in hepatocytes, monocytes, and MDSCs, induces the expansion of an immunoregulatory NK cell population, and triggers arginase release from MDSCs. Enhancement of these immunosuppressive activities may limit the effectiveness of Selgan, but also suggests potential therapeutic targets for combination therapy. Finally, oral Selgan dosed once a week was efficacious in about 40% of chronically infected woodchucks, demonstrating that Selgan treatment overall has a net positive effect on intrahepatic antiviral immunity, at least in a subset of animals. Switching gears and moving to the clinical studies. The design of the Selgan phase 1 studies are shown here. Selgan was safe and generally well tolerated at up to and including 3 mg in healthy volunteers and CHB patients. The most frequent treatment-related AE was nausea. Selgan induced a dose-dependent increase in serum cytokines and chemokines in both healthy volunteers and CHB patients. And here's that PD data from the healthy volunteers. There's a dose-dependent induction of cytokines and chemokines important for the expansion, activity, and trafficking of innate immune effector cells and various T cell subsets by Selgan. Maximum values for most biomarkers, including IL-12, P70, and interferon gamma, stood at 4 hours post-dose and declined thereafter, reaching approximately pre-dose levels by 24 hours post-dose. Importantly, as shown on the right, the PD response to 3 mg Cellgan in humans, which is a top dose selected for phase 2 studies, comparable to the PD response in woodchucks at the efficacious dose. As shown on the left, this is in sharp contrast to GS9620, the Gilead TLR-7 agonist, for which the PD response at a tolerable dose in CHB patients was markedly lower than that induced at an efficacious dose in the woodchuck model of chronic hepatitis B. The design of the multi-center Cellgan phase 2 studies is shown here. The aim of these studies was to evaluate the safety and efficacy of Cellgan for 24 weeks in CHB patients suppressed on an oral antiviral, or OAV, treatment, or Cellgan in combination with TAF for 24 weeks in viremic patients. The antigen positive and the antigen negative patients were randomized to receive 24 weekly doses of either 1.5 or 3 mg of Cellgan or matching placebo. Virally suppressed patients continued on nuke therapy throughout the Cellgan dosing period, and all patients were treated with nuke during the 24-week follow-up period. Primary endpoints were the safety and tolerability of Cellgan at week 24, and the proportion of patients with a greater or equal to 1 log S antigen decline from baseline at week 24. The table summarizes the safety data from the phase 2 studies. Cellgan was generally safe and well tolerated in both virally suppressed and viremic patients. Most treatment-emergent AEs were mild and all were self-limited. Like the phase 1 study, the most common adverse events were GI-related. Nausea was generally mild and dose-dependent, and most episodes of nausea were transient and did not recur with subsequent dosing. Like the phase 1 studies, there was a dose-proportional increase in various cytokines, such as IL-12, P40, IL-1RA, and interferon gamma levels with Cellgan dosing. Fortunately, there was no signs of tachyphylaxis across the dosing period. There's also dose-proportional decrease in CD3 positive T cells within 4 hours, which may reflect trafficking from the peripheral compartment into the liver. Finally, there was a comparable PD response in virally suppressed and viremic patients. Here is a high-level categorical summary of Cellgan efficacy in the phase 2 studies. In the virally suppressed patients, 2 patients achieved S antigen loss, 1 during treatment and 1 during follow-up. Both patients remain S antigen negative 18 months post-study and 12 months off nuke therapy. 3 patients who were e antigen positive at baseline achieved e antigen loss, 1 during treatment and 2 during follow-up. In the viremic patients, no patients achieved S antigen or e antigen loss by week 48. However, there was a greater S declines in the Cellgan-treated patients. Importantly, in both the virally suppressed and viremic Cellgan-treated patients, S antigen declines were sustained or continued to decline during the 24 weeks of follow-up. In summary, Cellgan is a potent and selective agonist of human TLR-8. Preclinical studies with Cellgan support its potential role in HBV cure as part of a combination regimen. Oral Cellgan up to 3 mg once weekly for 24 weeks was generally safe and well tolerated in both viremic and virally suppressed CHB patients. Cellgan induced cytokines and chemokines important for the expansion, trafficking, and activity of various innate and adaptive cell subsets in CHB patients. Cellgan showed modest antiviral efficacy in these phase 2 studies, with 5% S loss and 16% E loss in virally suppressed patients. Now, evaluation of Cellgan in combination with orthogonal antiviral and immunomodulatory agents is planned. To finish with my acknowledgements, I'd like to thank the patients, their families, and all participating investigators, as well as our collaborators at UCL and Georgetown University. Thank you for your attention.